nurse practitioner student, and today I will be performing the head-to-toe exam. Is that okay with you?
Yes.
Can you please tell me your first and last name and your age?
Jason Gallardo, 27.
Perfect. If at any point in time during this exam you feel any pain or tenderness, just please let me know, okay?
Okay.
To start off, I'm just going to do some hand hygiene. Alright, so I am first going to ask you some questions in regards to your orientation. Can you please tell me what day of the week it is?
Today is Saturday.
Can you tell me what month we are in?
It is the month of June.
And where are you right now?
I'm at my house.
Perfect. So next I am going to be discussing my findings for the general survey. Jason is a 27-year-old, healthy appearing, well-developed male. He is alert and oriented ×3. He is pleasant and responsive to questions. Jason's skin color is uniform and consistent with his ethnic background. Jason is well-groomed. He is dressed appropriately for the situation. He is sitting upright and he is in no apparent distress. Right, starting off, we are doing cranial nerve 1, which is his olfactory nerve, where I'll be evaluating his sense of smell. Starting off, I am just going to check the patency of his nostrils. So Jason, if you could please cover up one nostril and then breathe in. Good. Can you do on the other side? Good. There is good airflow bilaterally and both nostrils are patent. Now I'm going to be having you distinguish between two different scents. So I'm going to have you close your eyes and cover one nostril. Alright, can you please tell me what we smell?
Coffee.
Okay. Here is the second one. Can you please close your eyes and cover your other nostril this time?
Mint.
Perfect. So cranial nerve 1 is intact. Jason was able to differentiate between the two scents of coffee and mint. Alright, moving on to cranial nerve 2. This is his optic nerve. I'm going to be evaluating your vision. Starting off, I'm going to evaluate his vision using the Snellen chart. Looks like this. There is one 20 feet away from him. So Jason, do you wear glasses? Okay, so what I'm going to have you do is cover up your left eye and read the smallest line you can read on that chart.
LTFPH.
Good. He has good vision in his right eye, 20/20 without correction. Now can you please do it on your other eye?
LTFPH.
Alright, good. He also has 20/20 vision on his left eye with no correction. Okay. Now I'm going to be conducting a confrontation test, Jason. So what I'm going to have you do is stand up and face me. What I'm going to have you do is look at a distant image right across my shoulder. I'm going to be having you cover up your left eye. And then I'm going to be testing your visual fields of gaze, okay? Your visual fields. I'm going to be holding up numbers and you're going to tell me what numbers you see, okay?
4, 5.
Good. Now do it on your other eye.
3, 4, 5.
Good. You can go ahead and take a seat. So no defects found during the confrontation test. Visual fields are intact bilaterally. Alright, moving on to the fundoscopic exam, I am going to be using my ophthalmoscope. Jason, this might cause you some discomfort, so just bear with me. I'm going to have you look straight across at that chart once more. I'm going to be shining a light in your eye to evaluate his optic disc, retinal background, and that stuff, okay? So starting off with his right eye at a distance. Red reflex is visible and intact. Moving closer, his optic disc is round, creamy pink, margins are distinct and sharp. His central area of his physiological cup is pale. Cup to disc ratio is less than half. And then there is no increased cupping noted and no swelling noted. The visual of his retinal background is red and orange in color. His macula is slightly dark. Evaluating his vessels, his arteries are bright red, veins are slightly purple. artery to vein ratio is about 2/3, with the veins being larger than the arteries. No orthotosity of vessels noted, and no hemorrhages or exudates noted as well. Now I'm going to be doing it on his left side. Starting at a distance, red reflex is visible and intact. Getting closer, his optic disc is round, creamy pink. The margins are sharp and distinct. The central area of his physiological cup is pale, and there is no increased cupping noted, no swelling noted. And then his retinal background is red and orange in color. His macula is slightly dark. And then his vessels, arteries are bright red, veins are slightly purple. Arteries to vein ratio is about 2/3, with the veins being larger than the arteries. No tutoricity of vessels noted, and no exudates or hemorrhages noted as well. Moving on to cranial nerves 3, 4, and 6. All of these are nerves that mediate the movements of the eye. So cranial nerve 3 is his ocular motor nerve. These mediate the pupillary constriction and the levator muscles that move or raise the eyelids. Cranial nerve 4 is his trochlear nerve. Trochlear nerve that mediates the inferior medial movements of the eye via the superior oblique muscles. Cranial nerve 6 is his abducens nerve that mediates the movement of the lateral eye movements via the lateral rectus muscle. So first, I'm going to be evaluating his pupils with a pen light. Alright, Jason, I'm going to shine a light in your eye twice. First one, I'm going to check for any direct response, and the second one, I'm checking any consensual response in the opposite eye. Go ahead and look straight ahead. Right, there is a direct response is intact. Now I'm going to do the consensual side, looking at his opposite eye. Wonderful. Consensual response in the opposite eye is intact. I'm going to do the same concept on his left eye. Alright, there's a nice direct response and it's intact. Now for the consensual. Alright, there is consensual response in the opposite eye is intact. Next, I will be evaluating his extraocular movements in the 6 cardinal fields of gaze. So Jason, I'm going to have you stand up, and then you're going to follow my finger. You're going to follow my finger. Good. Extraocular movements are smooth and full. No nystagmus or paralysis of the eye muscles noted. Now I will be performing the corneal light reflex. You're going to look at me. I'm going to shine a light at the bridge of your nose, okay? Alright, I see symmetrical light reflex during the corneal light reflex test. Now I will be performing the uncover cover test. So Jason, stay right there. During this exam, I'm going to be evaluating if you have any ocular deviations, any misalignments, or any strabismus. So I'm going to be covering up one eye at a time and then uncovering at the same time, okay? Cover, uncover, cover, uncover. Now doing it on your left eye. Cover, uncover. Good. Eyes remained aligned bilaterally. No ocular deviations noted. You can go ahead and sit. I did miss a exam part. I forgot to check accommodation, so I'm going to do that right now. Jason, I'm going to have you look straight ahead. I'm going to put my finger right in front of you, and then you're going to look straight at it, okay? Oh, no, don't look straight ahead.
Oh.
Yes. And then when I place my finger in front of you, you're going to look directly at it, okay? Alright. Perfect. Patient has perla. Pupils are equal, round, reacted to light and accommodation. They were able to converge bilaterally. Moving on to cranial nerve 5, this is his trigeminal nerve. It contains both motor and sensory function. To evaluate his motor function, Jason, I'm going to have you move your jaw side to side. Wonderful. No limitations to the muscles of mastication. Now I'm going to have you grit your teeth while I'll palpate your masseter muscles. Wonderful. There is a good, strong, direct response. For the sensory part, I am going to be making him distinguish between soft or dull and versus sharp. Above his eyebrow, on his cheek, and on his chin while he has his eyes closed. So go ahead and close your eyes and you're going to tell me when you feel sharp or dull.
No. 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 Sharp. 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 Sharp.
Very good. Cranial nerve 5 is intact. Jason was able to have sensation intact in all 3 distributions of the trigeminal nerve. Now moving on to cranial nerve 7, this is his facial nerve, this is his facial nerve, which also has motor and sensory function. For sensory, we are going to skip this portion of the exam, but usually we test the taste on the anterior 2/3 of the tongue. For the motor function, I'm going to have you puff out your cheeks. Give me a big smile. Show your teeth. Wonderful. And then cranial nerve 7 is intact. Now moving on to cranial nerve 8. This is his acoustic nerve, where I'm going to be evaluating his hearing. Starting off with the whisper test, Jason, I'm going to have you cover one ear. I'm going to go behind you and whisper 3 words, and you're going to repeat after me.
Red, black, and blue.
Good. Now cover the other ear.
Paper, round, blue.
Good. Right. Jason has good hearing bilaterally. Now I am moving on to the Weber test. During this exam, I am going to be using a tuning fork. Jason, when I strike this tuning fork, I'm going to place it right above your head. You're going to tell me if you hear the sound equally on both ears or if you hear it more than the other ear, okay?
Hear both sides.
Okay. No lateralization of sound. If the sound was lateralized to the affected ear, that would be conductive hearing loss. If the sound was lateralized on the non-affected ear, that would be sensorineural hearing loss. Now moving on to the Rhine test. During this exam, I'm as well using the tuning fork. Jason, when I strike the tuning fork, I'm going to be placing it right here across your bone. When you stop hearing that, I'm going to place it right across your ear, and you're going to let me know when that finishes as well, okay? I have a timer here on the side to basically let me know when everything is done, okay?
Don't hear anyone. Don't hear anyone.
Okay, now I'm going to do it on the other side.
Don't hear anyone. Don't hear anyone.
Okay, air conduction is greater than bone conduction, with the ratio being 2 to 1, which is expected. No conductive or sensorineural hearing loss. Right, moving on to cranial nerve 9 and 10. These are assessed together, which they also have a sensory and motor function. Cranial nerve 9 is your hypoglossal nerve, and cranial nerve 10 is your vagus nerve. To evaluate the sensory part of this test, it is cranial nerve 9. We will skip it, but it is evaluating the taste on the posterior 1/3 of the tongue and throat. The motor function of this is I'm going to shine a light in Jason's mouth to evaluate his uvula and gag reflex. I'm going to have you open your mouth and say on. Okay. Uvula rises and falls at midline. No deviation. Now I'm going to test his gag reflex. Say on. Alright, gag reflex is present. Now I'm just going to have you swallow. Alright, cranial nerve 9 and 10 are intact. Moving on to cranial nerve 11. This is his spinal accessory nerve, which is a motor nerve. Jason, I'm going to actually have you stand for me and face me. I'm going to place my hands on your shoulders and you're going to shrug against the resistance. Good. He is able to shrug his shoulders against resistance. Now I'm going to place my hand against your cheek and you're going to try to turn your head against my resistance. Good, and on the other side. Alright, Jason has good motor nerve of cranial nerve 11. He was able to move against my resistance. Go ahead and take a seat. Alright, now moving on to cranial nerve 12. This is his hypoglossal nerve. I'm going to be evaluating the movements of his tongue. So Jason, first I'm going to have you stick your tongue out. Good. Tongue protrudes at midline, no tremors or deviations noted. Now I'm going to be placing my palm against his cheek. Jason, I'm going to have you push your tongue against the cheek. Good. Now other side. Okay. Jason has good movements of his tongue. He was able to push his tongue against his cheek. Cranial nerve 12 is intact. Alright, now we are moving on to the inspection and palpation part of our exam. Starting off with his head and face. Hair is soft. It is equally distributed. No signs of alopecia noted. Evaluating his skull and his scalp. It is normal cephalic, no masses, lesions, ulcerations noted. Moving on to facial features. Facial features are symmetric. Skin is dry, pink, and smooth. No swelling, lesions, ulcerations noted. Now I'm going to be palpating his frontal and maxillary sinuses. Jason, you're going to tell me if you feel any tenderness, okay? Any tenderness?
No.
No maxillary sinuses? Any tenderness?
Nope.
Good. No tenderness noted upon palpation of his frontal and maxillary sinuses. Moving on to the eyes. Eye structures are symmetric. No ptosis noted. Sclera is not Duric. Conjunctiva is pink bilaterally. No crusting, lesions, ulcerations, or edema noted on his eyelids or his eyelashes. Cornea is clear without any opacities, and the iris is flat. Moving on to the ears, I'm going to inspect and palpate. His ears are in alignment with the outer campus of his eyes. Auricles are non-tender, no erythema, no swelling, no skin tags noted. Now gonna be palpating his mastoid process. No masses noted, any tenderness?
Nope.
No tenderness noted, no erythema, no swelling noted. Now I'm going to be doing the tug test. I'm going to tug his ear up and then back. Any tenderness or pain?
Nope.
Alright, no tenderness or pain noted. No signs of otitis externa on his right ear. Any pain?
Nope.
Alright, no tenderness or pain noted. No signs of otitis externa on his left ear. Moving on to the otoscopic exam with my otoscope, I'm going to be looking at the structures inside of his ear, okay? Alright, the external auditory canal is pink. No excess serum, no lesions, ulcerations, or masses noted. Tympanic membrane is pearly gray. Neutral, no bulging, no effusion, no erythema. Cone of light is 5 o'clock. The handle and short process of the malleus is visible. Alright, the external auditory canal is pink, no serum excess, no lesions, ulceration, or masses. The tympanic membrane is pearly gray, is neutral, no bulging, no erythema, no effusions, and the cone of light is at 7 o'clock. The handle and short process of malleus is visible. Now I am going to be evaluating his nares, moving on to the mucosa. Jason, I'm going to have you tilt your head back, and I'm going to use my otoscope to evaluate the inside of your nose, okay? Alright, mucosa is pink and moist, no bleeding, no swelling, no polyps noted on his right nare. Moving on to the left side. Alright, mucosa is pink, no erythema, no polyps, no bleeding or swelling noted as well. I evaluated for any septal deviation. No septal deviation was noted. The inferior and medial turbinates are visible, and the superior turbinates are not visible. Alright, now moving on to the throat for inspection. First, I'm going to start off with his lips. Lips, there's no ulcerations, lesions, cracking, or dryness noted. Now, I'm going to be inspecting his throat on the inside with my pen light and the tongue depressor. Can you open your mouth, say ah? Alright. Okay, after evaluating his mouth, buccal mucosas were pink and moist bilaterally. No redness, no lesions, ulcerations noted bilaterally. Evaluating his gums, they were pink and moist as well. No bleeding, no ulcerations or lesions as well. His teeth are aligned. Good hygiene is noted. Evaluating the roof and base of his mouth, no petechial lesions noted, no bleeding, no lesions or ulcerations noted as well. His tongue, can you stick out your tongue for me? Good. His tongue is pink and moist, no white patches, no ulcerations as well. Now I'm going to have you open up your mouth. I'm going to be evaluating the tonsils, and you're going to say ah. Good. His tonsils are 2+ in size, taking up about 50% of the space, which is accepted. Now I will be evaluating his oropharynx using the Mallamphy-Urey classification, which is graded from 1 to 4. 1 being that you can visibly see the full soft palate and uvula and pillars are completely visible. Grade 4 is the hard palate is only visible. This will basically give us the size or space available for intubation, or allow us to visualize if he has any risk for obstructive sleep apnea. So I'm going to grab my pen light. I'm going to have you open your mouth and say ah, okay? And go open your mouth and say ah. Good. So whole uvula and soft palate is visible. Grade is 1+. Oropharynx is pink and moist, no ulcerations or lesions noted. Alright, moving on to his neck. First, I'm going to inspect it. Neck is midline and symmetrical. No deviations noted. No jugular vein distensions are noted. Now I'm moving on to the palpation part of his neck. So, find his sternal notch, work my way up. Alright, trachea is midline, no deviations noted. Now I'm going to be palpating his thyroid, which I'm going to step right behind you. I'm going to palpate on both sides. Can you swallow, please? Alright, no masses or nodules noted. I'm going to have you turn right, kind of slightly look down. I'm going to displace his thyroid to the right and palpate. Alright, no masses or nodules noted. Now turn left, kind of look down. I'm going to displace his thyroid to the left, palpate. Alright, no masses or nodules noted upon palpation of his thyroid. Now I'm moving on to palpating his lymph nodes. So first, his pre-auricular lymph nodes, his post-auricular lymph nodes, his occipital lymph nodes, right, and then his tonsillar lymph nodes, his submandibular lymph nodes, and his submental lymph nodes, his anterior superficial cervical lymph nodes, his deep cervical lymph nodes, his supraclavicular lymph nodes, and then his inferior clavicular lymph nodes. Alright, upon palpation, his lymph nodes are less than 1 centimeter in size. They are mobile and soft, so it's a normal finding. If they were abnormal, it would be enlarged, fixed, or tender. Alright, moving on to the thoracic posterior chest. Jason, I'm going to have you stand and face your back to the camera. To keep the modesty for this video, I'm not going to have them take off his shirt. I'm going to explain the findings that would be not concerning. So posterior thoracic is symmetric in size and shape. No visible nevi, scars, masses, or lacerations would be noted. Skin is pink, dry and smooth, and appropriate for ethnic background. Spinous process is straight. Scapula is symmetric. No unusual curvature. No structural abnormalities noted. The A to P ratio is 1:2, and patient is relaxed and not in any apparent distress. Right, moving on to the palpation part of the exam. Jason, can you please stand up? I'm going to palpate the posterior thoracic chest. Okay. Just going to do it here. Any pain or tenderness?
Nope.
Right, no pain or tenderness noted. No masses, no heaves, no throws noted as well. Moving on, I'm going to be checking his respiratory expansion. So I'm going to place my hands under T10, and Jason, I'm going to have you breathe normally. Alright, it is symmetric bilaterally, expansion is symmetric. Now I'm going to be doing tactile firmness. So Jason, what I'm going to have you do is say 99 every time you feel my hands on your back, okay?
99, 99, 99, 99.
Wonderful. Vibrations are symmetric, clear, and strong. No dullness or fluid noted. Right, now I'm going to be percussing. If there is resonance, that means that there is hollow, clear, low-pitched lung sounds. If there is dullness, that means there's consolidation. If there is hyperresonance, that means there is increased air-filled areas, such as with emphysema or COPD. Flat sounds are over bones. So I'm going to be percussing in 8 different sites. Alright, all lung sounds are resonant. Now I'm going to be checking for CVA tenderness. This is below the 12th rib. Please let me know if you feel any pain or tenderness, okay? Any pain or tenderness?
Nope.
Any pain or tenderness?
Nope.
Alright, no pain or tenderness, negative for CVA tenderness. Alright, go ahead, just sit down. Great. I'm gonna have you face. Yeah, that's okay. I'm gonna be moving on to the auscultation part of this exam. Alright, first I'm going to clean my stethoscope. Alright, I'm gonna have you sit up, lean slightly forward. Alright, and then every time you feel the stethoscope on your back, take a breath in. If you start to feel dizzy, just stop, okay? Okay, good. Now, every time you feel the stethoscope on your back, I'm going to have you say E, okay? I'm just evaluating your egophony. Okay, go ahead and forward. Can you actually have your back face the camera?
E, 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 E.
Alright, I was only able to hear the muffled E, no changes to A, and no fluid or consolidation was heard. And so lungs are clear to auscultation bilaterally. Moving on to the thoracic anterior chest, I'm going to be inspecting first of his chest. To keep modesty, I will not be taking off his shirt. Can you just sit up for me? Alright, anterior chest wall is symmetric in size and shape. AP diameter is less than half of the transverse diameter. Shoulders are symmetric. No lesions, scars, nevi, masses are visible. No structural abnormalities visible. Skin is smooth, pink, dry, consistent with ethnic background, and it's appropriate. Okay, now I'm going to be evaluating his respiratory rate and rhythm. I'm going to have you sit quietly and relax, and then I'm going to be just evaluating your respiratory. Alright, his respirations are smooth, no accessory use or no use of accessory muscles are noted. It is quiet and rhythmic. Okay. Moving on to palpation, I'm going to be palpating starting down and out. Do you have any tenderness? Alright, no tenderness or pain noted upon palpation. Alright, moving on to the auscultation part of the anterior thoracic chest. If I am listening for bronchial breath sounds, it is located in the upper part of the respiratory tree. Bronchial vesicular breath sounds are heard over the bronchi, and then vesicular breath sounds are heard over the peripheral lung tissue. Sorry. So I'm going to be listening for one full respiratory cycle on each. Right, lung sounds are clear to auscultation bilaterally. Alright, moving on to the cardiovascular system. First, I'm going to be labeling the major landmarks, starting off with the aortic. This is located on your second intercostal space along your right sternal border. This is again known as your aortic. S1 is heard best here. It is also known as the base of your heart. Right across from that, along your left sternal border on your second intercostal space is known as your pulmonic. Split S2 is heard best here, and this is the only sound that may vary during inspiration. Right below that, on your third intercostal space, along the left sternal border, is your Erb's point. And then right below that is your tricuspid, which is along the fourth intercostal space along your left sternal border. Split S1 is heard best here. To locate your mitral, it is on the fifth intercostal space along the midclavicular line. This is again your mitral, and S1 is heard best here. If a patient is laying on the left lateral decubitus position, S3, S4, and mitral valve prolapse would be best heard at those points. Lastly, in the epigastric region, right below your xiphoid process and slightly left, you may feel any pulsations if there is any heart hypertrophy. It is also important to know that mitral regurgitation murmur and aortic stenosis is best heard during systole. Okay, changing positions, we are now going to differentiate between a squat test and the Valsalva maneuver. During the squat test, I'll be listening to his mitral point, and then I'm going to have him squat while listening to his mitral point. Now squat. Alright. If there was a click and it resolved, then it would be indicative of mitral valve prolapse. If the click were to increase, then it'd be indicative of the snapping of aortic stenosis. Now we are going to move on to the Valsalva maneuver. I'm going to have you lay down. As he is laying down, I am going to be placing my hand on his abdomen and ask that he bears down as if he was taking a bowel movement. And then I am again listening to his mitral point area again. Go ahead and bear down. Okay. So as he is bearing down, if the click increases, then it may be indicative of mitral valve prolapse. If the click were to resolve or decrease, then it would be indicative of aortic stenosis. Alright, moving on to inspection and palpation. To keep the modesty for the video, I'm not going to lift his shirt, so I'm just going to state that there's no visible thrills or pulsations, lifts, or heaves visible. Moving on to palpation, I am going to palpate all precordial sites, evaluating for any heaves or lifts with the fat of my fingers, and for thrills, I am going to be using the ball of my hand. Starting off with heaves and lifts. No heaves or lifts noted upon palpation. Now I'm going to be doing thrills with the ball of my hand. Alright, so no thrills or palpations felt upon palpation. When I palpate the apical pulse, which is along the fifth midclavicular line, it should be about 2.5 centimeters wide and about less than 2/3 of systole. If the apical impulse is laterally displaced, then it could be indicated of an enlarged heart. If the apical impulse is hyperkinetic, it could be to young age, recently exercised, hyperthyroidism, aortic stenosis, or aortic regurgitation, or anemia. Now moving on to the auscultation. First, I am going to be auscultating with the diaphragm of my stethoscope. Then I will be auscultating with the bell of my stethoscope in all 5 precordial sites. Alright, after auscultation, heard regular rate and rhythm, heard S1 and S2, no S3, no S4, murmurs or rubs or gallops heard. Usually I would then place the patient in a left lateral decubus position and re-listen with the diaphragm and bell of my stethoscope. For the sake of the time of this video, we will skip that. Alright, moving on, I'm going to be auscultating for any bruits with the bell of my stethoscope. My patient will be lying supine in a 30-degree angle. First, starting off with the carotid arteries. When I place my stethoscope on each carotid artery, Jason will be holding a breath. Hold your breath. Breathe. Hold your breath. Breathe. Alright. No worries noted bilaterally on his carotid arteries. Now I'm going to be moving on to his abdominal aorta. It is located right below his xiphoid process and above his umbilicus midline. Alright, no bruise noted upon auscultation of his abdominal aorta. Now we are moving on to his renal arteries, which is slightly below his abdominal aorta and lateral to midline bilaterally. Alright, no bruise noted upon auscultation of his renal arteries. Now we are moving on to his iliac arteries. These are located below the umbilicus and lateral to midline bilaterally. Alright, no bruise noted upon auscultation to his iliac arteries bilaterally. Now we are going to move on to his femoral arteries. These are located halfway between the superior iliac spine and pubic symphysis with the groin region bilaterally. Alright, no worries noted upon auscultation to his femoral arteries. Alright, moving on to palpation of his pulses. Pulses are graded from a 0 to 3 plus scale, 0 being no pulses felt, 1 plus being weak, 2 plus being brisk, which is expected, and 3 plus being pounding. Starting off with his radial pulses, I will evaluate for 60 seconds on each side. Alright, 2 plus on his right radial pulse. Alright, 2 plus on his left radial pulse. Now I'm going to be palpating his femoral process, which is halfway between the superior iliac spine and pubic symphysis bilaterally, right below the inguinal ligament. Alright, 2 plus femoral pulses bilaterally. Now I'm going to be evaluating his popliteal pulses. Jason, I'm going to have you bend your knees. I am going to be placing my thumb on top of his knee and my other fingers pushing against on the back to feel his pulse. Alright, 2 plus pulses bilaterally on his popliteal pulses. Now moving on to his posterior tibialis. These, I'm going to keep his knees bent, and slightly below the medial malleolus is where I'll be palpating for his pulses. And then, please. Alright, 2+ on his posterior tibialis pulses. Now moving on to his dorsalis pedis, I'm going to keep his knees bent, and on top of the foot, just lateral of the extensor tendon on the great toe is where I'll be palpating for his dorsalis pedis. Go ahead and bend here. Alright, Jason has 2+ dorsalis pedis pulses bilaterally. Alright, moving on to evaluating for any edema. I'm going to be checking all his extremities. If Jason has any pitting edema, it is characterized as soft, not palpable swelling, that if I leave a depression with my thumb and it lasts 1 to 2 seconds, that is pitting edema, usually graded on a 4+. If Jason has dependent edema, it is a type of pitting edema, but usually due to prolonged sitting or standing. If Jason has anascara edema, it is generalized edema, usually due to liver or kidney failure. Okay, just gonna be checking. Gonna check your legs. This one. Alright, no edema noted on all 4 extremities. Skin temperature is warm and in upper and lower extremities as expected. I'm gonna basically check for skin turgor at below the collarbone. Alright, for skin turgor, no tenting is noted. I'm going to now check for capillary refills. I may check on your toes.
Yes.
Alright, capillary refills in upper and lower extremities is less than 2 seconds with the smooth nails. Okay. Alright, moving on to his abdomen. First, I am going to inspect it. Keep modesty for the video. I'm not going to make him move his shirts, but I would normally state that his abdomen is slightly protuberant. It is symmetric, no visible striae, nevi, masses, or lesions visible, no dilated veins, and no pulsations are visible. If pulsations are visible, that can be indicated of AAA or aortic and abdominal aortic aneurysm, and that would not be palpable. Alright, now moving on to auscultation. I'm going to auscultate his abdominal area, his liver, and his spleen, usually in a span of 1 to 5 minutes. Starting off with the right lower quadrant, I'm going to do all 4 quadrants, then move to the liver and spleen. Alright, Jason's bowel sounds are normal, active in all 4 quadrants. Now I'm going to be listening over the spleen and liver for any friction rub. If a friction rub is characterized as a grating sound, that may vary with inspiration. If there is a friction rub heard over the spleen, it can be indicative of inflammation of peritoneal surface of organs, possibly from tumor or chlamydia, gonorrhea, or splenic infarct. If there is a friction rub heard over the liver, it could be due to hepatic carcinoma. No friction rub heard over his spleen. Moving on to the liver. No friction rub heard over the liver as well. Now I'm going to be listening for any venous hum, which is a soft systolic and diastolic hum that may be heard over the liver, epigastric, and umbilical region. It can indicate increased collateral circulation or with hepatic cirrhosis. Alright, no venous sound heard on auscultation. Moving on to percussion, I'm going to first percuss Jason's abdomen starting from the right lower quadrant. Then I'm going to be checking for any hepatomegaly. Alright, sound is tympanic in all 4 quadrants of his abdomen. Now I'm going to be checking for hepatomegaly. I'm going to start percussing with my finger along the 3rd intercostal space along the midclavicular line. I'm going to percuss down until dullness is heard and work my way right below my umbilicus along the midclavicular line and move up until tympanic to dullness is heard. Alright, so no hepatomegaly noted. It was measuring between 6 to 12 centimeters. It is 8 centimeters for this patient. Now I'm going to be doing light and deep palpation on my patient, and then I'll be palpating for any hepato or splenomegaly. Any tenderness?
Nope.
Deep palpation?
Nope.
Now I'm going to be evaluating for any hepato or splenomegaly. Alright, no hepato or splenomegaly noted. No pain or tenderness upon light and deep palpation. Alright, moving on, I'm going to be testing for appendicitis, starting off with the first exam. It is called the Sosa sign. I'm going to place my hand against his thigh and have him raise his leg, and he's going to tell me when he raises it if there is pain or not.
No pain.
Moving on to the obturator sign, I'm going to have his knees bent and do an internal rotation of the hip. If he feels pain, that is indicative of appendicitis.
No pain.
Alright, now I'm going to be doing rebound tenderness. During this, I will palpate his left lower quadrant. When I release, if there is pain, then it's indicative of appendicitis.
No pain.
Right, no pain noted. Now I'm doing the Rossfing sign. I'm going to press deeply in his left lower quadrant and then release the pressure quickly. If there is pain to his right side, the opposite side, then it is indicative of appendicitis.
No pain.
Alright, so no appendicitis noticed upon exam. Now I'm going to be testing for cholecystitis. I'm going to press my fingers right under his right rib cage, and then if there is pain with deep inspiration, then it means it's a positive Murphy sign, and it means that there is inflamed gallbladder.
No pain. No pain. Okay.
Alright, negative for Murphy sign. Alright, moving on to the neuro exam, I'm going to be evaluating his balance and coordination. With the first exam, I'm going to have you walk towards the camera and then walk back. I'm going to be evaluating his gait. Alright, wonderful. Gait is smooth and steady, natural arm swing, no steppage gait. Now we're going to be performing the Romberg test. I'm going to have you close your eyes and stand there for 1 minute. Alright, 1 minute has passed, negative Romberg as expected. Now I'm going to have you sit down and we're going to be performing the point-to-point test, where I'm going to have you touch your thumb with your fingers as fast as you can. Good. movements are smooth and accurate. Now I'm going to be doing the exam where I'm going to have him touch his nose and touch my finger on both sides. Wonderful. I'm doing the other side. Sorry. Alright, movements are smooth, accurate, no tremors or fasciculations noted bilaterally. Now we're going to be doing the heel to shin. Jason, starting off with your right, you're going to graze your heel up to your shin just like so. Do it one more time. Now please do it on your other leg. Alright, good movements. It is smooth and it is accurate. Now we're going to do the pronator drift. I'm going to have you hold your arms out and in front of you. Hold it for 10 seconds. 10 seconds pass. Go ahead and relax. Now do it again with your eyes closed. Alright, 10 seconds has passed. No pronator drift noted. Alright, moving on to sensory function. I'm going to have Jason differentiate between dull and sharp. So go ahead and close your eyes.
Sharp, 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 sharp. Dull, 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 dull. Sharp, 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 sharp.
Alright, wonderful. Jason was able to differentiate between dull and soft. Sensation is intact. Alright, moving on to discriminative sensation. Jason, I'm going to have you close your eyes for this first one. I'm going to place something in your hand and you're going to tell me what I put.
A coin.
Wonderful. Stereogenosis is intact. Now, keeping your eyes closed, I am going to draw on your hand and you're going to tell me what I drew.
An 8. L.
Right. Graphesthesia is intact. Discriminative sensation is intact bilaterally via stereogenosis and graphesthesia. Moving on to the last part of our head to toe, I'm going to be evaluating for any meningeal signs. So I'm going to manually move Jason's head to his chest. Alright. No flexion of his knee or hip was noted. There was nice smooth movement, so that is a negative Radomski's test. Now, as he is laying down, I am going to elevate his legs and straighten them up. Any pain?
No.
Any pain?
No pain.
Alright, no pain noted upon levitating his legs. I did not feel any tension or any resistance when I did straighten his leg. That is a negative Kernig sign. So that concludes our head to toe exam. Thank you.